Now have the distinct pleasure of introducing Dr. Joe Beiske, who is the President and Chief Executive Officer of the American Board of Surgery. And she's here just to give a brief update on the hospice and palliative medicine. I'd say the changes in the hospice and palliative medicine fellowship as it pertains to surgeons. So thank you so much, Dr. Beiske. We appreciate you being here.
I have to say that panel is a very tough act to follow. I feel a little intimidated, and I actually brought notes up because I took so many notes because I learned so much while I was listening there. I am, however, going to riff off of the very last talk because I'm an English major. I come from a family of English majors. My grandfather was a professor of English, my sister-in-law, my sister. We talk about English all the time, and I cannot help but tell you a couple of important things. One is that the word unique cannot be modified. It's an absolute. You cannot say that something is very unique, which I did here in this conversation. The second is that the word consensus means general. So you can't say general consensus. You can't say general consensus of opinion. Consensus means general opinion. I just thought I would share those with you while we're at it. Emergent surgery is not a thing. It is emergency surgery. The word emergent means emerging, not emergency. And patients cannot endorse symptoms. So now that I've got that off my chest. So I want to start by saying that I am very sorry that many of you, or if any of you, perceive the change in certification from ABS to ABIM as diminishing the value of this field, because that is very much not the case. The board, I can speak for the board and for myself personally, that palliative care is an essential component of healthcare, of health in this nation, of mental health. For myself personally, my daughter keeps a list of things I want at end of life, including the songs, the ever evolving playlist for my funeral, as well as the request that I get a palliative care consult as soon as possible for my terminal hospitalization. For the council, which is sort of the think tank of the board now, we have a governing board, which is sort of a corporate board responsible for the finances, the strategy, the reputation of the board. And then we have the workforce that used to be called the board and is now called the council. And we elect people by what are perceived to be the needs of the council, to the knowledge needs and skills of the council to carry forth their mission of protecting the public and enhancing the profession, essentially. And palliative care, expertise in palliative care, has been on the list for the last several years, which is why Bridget Fahey-Shandon is on the council. And I'll have more to say that about the end. I didn't get a lesson in this, so I'm just going to assume I can figure it out. Oh, I can. So I always like to start with the mission statement of the board. This is actually brand new. We revised it over the last year. And I particularly want to just draw your attention to the middle one, which is rigorous evaluation and assessment, because we are standard setters. And to set a standard, you need a certain volume. You can't set a standard on one person. To set a standard on exams, there's a ratio, actually, which I learned on the job, of number of people who take the exam versus number of questions. There's absolute minimums for both. And to have any kind of validity in an exam, you really need about 100 people to take the exam in the first place. So those are just sort of basic, but you can imagine you need a certain number of people to set standards. That fact is not related to the value of the work that's being done. There's no doubt that having pediatric surgical critical care specialists is incredibly valuable in this country, but they exist in single digits. So we can't write exams for them. They would have to write their own exams. There aren't enough of them to do anything else. It doesn't mean they're not valuable. It just means they don't fit in our existing processes. So I prepared this whole thing without ever defining what the difference between a sponsoring board and a qualifying board is. So I actually just added this about an hour ago. So we used to be a sponsoring board. I actually joined the board staff in early 2009, right after the first exams in hospice and palliative care medicine. So I wasn't involved in those decisions, but I did hear a lot of sidebar conversations because it was an active discussion at the time. And ABS actually wasn't interested in participating. They didn't think there were any surgeons who did palliative care. They did not think there were any. But American Board of Internal Medicine was like, "You sure? I think there might be. I think it might be important for you to hold the door open." So that's really what our relationship has been all this time. And we do that for a couple of other smaller specialties, is to hold the door open so that surgeons aren't disadvantaged by the existence of this certificate, so that a hospital can't say, "Oh, you, pediatric surgeon, do not have a certificate in surgical critical care, so you can't be in the ICU." We hold the door open that pediatric surgeons can be certified in surgical critical care. And to the same idea, we didn't want to, or actually internal medicine persuaded us not to have the door shut on surgeons. So I was there when the results of the first exam came in, and I remember the surprise that there were double-digit people who took the exam. Frank Lewis was just like, "Can you believe it? This many people took the exam." So we were a sponsoring board at the time. And I will say, we move in the waters, the greater waters of the American Board of Medical Specialties, which is sort of the Uber board that oversees everybody. I always thought there was only the American Board of Surgery until I joined the board, essentially, and realized there's boards across 24 of them actually across every specialty. So a sponsoring board means that there's a field that crosses multiple different specialties, and a sponsoring boards work in partnership, theoretically equal partnership, but not usually, with a lot of responsibility. They help define eligibility requirements. They do the sort of practical work of how you document those requirements, writing the exams, managing the applications, dealing with the diplomates, issuing the certificates, and importantly, maintaining the certificates through continuous certification, or until recently, recertification, that once every 10 years high stakes exam. And I just want to, remember that middle line about setting standards through certification. A qualifying board, on the other hand, is a board that holds the door open so that our diplomates can move on and get this certificate. We were actually a qualifying board. Or actually, I take that back. We were a sponsoring board, but all of the surgical boards were qualifying boards until this change. So that if an orthopedic surgeon, of which I think there was one, wanted to get an HPM certificate, they came through us, and then were ultimately certified by us, not ortho. A few plastic surgeons, a few OBGYN, one otorhinolaryngologist, hello. No neurosurgeons. And so they were qualified through us. We held the door open. So that's the distinction, if that's helpful at all. And what's the history? That the certificate started in 2008. Those were the boards that were qualified through us, not all. It's sort of alphabet soup. You can kind of piece it out if you think about it. American Board of Orthopedic Surgery, Urology, Plastic and Reconstructive Surgery, Colorectal Surgery. Interestingly, I don't think any colorectal surgeons actually ever applied to us. You would think they might have. Thoracic surgery, you would also think some thoracic surgeons have been married to a thoracic surgeon. I know they needed palliative care and neurosurgery. In 2012, the legacy pathway was discontinued. So that you couldn't get a certificate in palliative care by practice. That is an absolute rule of the combination of the ACGM and the ABMS. Once you have certification, you have got to close the practice pathways. There may be possibly a little window of exception through the AIR pathway, the sort of experimental pathway at the ACGME, but I did hear someone say they were interested in the practice pathway. It makes a lot of sense to me, but we should talk about how you might pursue that. Don't get too far down the road without learning the rules. And then in 2018, so it was all fine. The ABIM did all the work. We were theoretically sponsoring boards, but they made the rules. We sort of had someone in the back of the room at the meeting saying, fine. They wrote the exams. They invited surgeons to participate. Some people in this room actually did. Any raise hands for the people who participated in exam writing? Right, so we had a few surgical volunteers, obviously very much dwarfed by the primary care boards. And then there was the 10-year recertification exam. They wrote that too. They told us how many people had taken it. We funneled people with the qualifications through our board, and that was really our full relationship. And over time, they started saying, like, you're not really doing anything. You don't really have a lot of participation. Would you like to just become a qualifying board? So we, we're interested in that offer. just for bandwidth issues, but we didn't really pursue it for a little while. The deciding point came when all of the boards dropped that every 10-year cycle. And you know from your own practices that going for 10 years between being evaluated for your surgical knowledge is just way too long, right? If you look back to what you were doing 10 years ago, when I rounded in the ICU a couple of weeks ago, almost no medication and no procedure the patient was on had been in existence 10 years ago. And so I'm fully behind the 10-year exams not being valid. So we moved to an every other year assessment. Some of you may have taken it. If you did, I hope that you learned something. I did. I'll tell you though that the general surgery module this year is really hard. The GI surgery module is easier. But all the boards develop their own continuous certification or longitudinal certification. So we would have had to do that for HPM. To develop an exam of any kind is exactly the same amount of work for the staff if it's for 5 people or if it's for 5,000 people. The writing of the exam, the vetting of the questions, the psychometrics, the developing of the application, it is the same amount of work. Not only that, you need a workforce. You need about 30 people every year to do an exam who then aren't really eligible to take the exam. So it's complicated. None of those things are insurmountable. I don't want to say that any one of them was really the issue. It really sort of became a practical issue. So in 2022, the ABIM really did a marvelous job of sort of smoothing the pathway, promising a home for everybody. And most of the old sponsoring boards switched over to become qualifying boards. Only the largest boards involved, with the exception of ABA, decided to stay as sponsoring boards. And so just for a little bit of, the sort of backup history, you only need to look at the top line. And which is the number of people who are certified over the last 10 years. That was actually what was easiest for me to find, which is on the ABMS website. So in 2012, which was the last year of the legacy pathway. So the last year that people who had not done a fellowship could still certify. So there's always a big rush for that, because it's kind of anybody who thinks they may even possibly want to be certified wants to do it then. So 36 people in 2012, 7 in 14, 3 in 16, 8 in 18, and 7 in 2020. So those numbers are pretty low. They're also staying stable. I know that there's a feeling that there may be an increase in surge, but even if there is, it'll be some time before you reach the sort of magic 100 mark. So that's where we've been sitting in terms of number of people who were certified through us, including the one otorhinolaryngologist and the handful of other surgeons. And so these are the boards that decided to stay as sponsoring boards, our old role. So the people who go through those boards will get certificates from their own boards. And you can see they're all kind of double digits at least every year. And these are the boards that opted to become qualifying boards. And for the most part, they're the single digit every year people. You can have those. I'll give them to you if you want. I think I already did. Actually, I had to email them to somebody to get these here. And then to look at our other ABS boards, just for sort of some comparison, this is the number of diplomates we have for each board. So the bottom 3, complex general surgical oncology, that's new. They've only been around for 6 years. So we get more of those every year. That'll continue to grow. We get, between 80 and 120 new diplomates a year from that group. Hand surgery, don't even talk to me about that. It is a really, really old, really complex relationship with orthopedic surgery and plastic surgery. And when I have the bandwidth, we will address it. And then we had, as of earlier this year, 75 diplomates across all the years, not just going back 10, but going back all the way to 2008 in HPM. We had 85 people who were ever certified. But some people drop out, often the legacy people. And if you don't mind for 1 second, I'm also going to do a very brief education that we don't use the term grandfather clause anymore, because it comes from the Reconstruction era, when in the South, they were trying to prevent Black people from voting. And so they first set a rule that said you can't vote if you can't read. So most Black people had not had the opportunity to learn how to read because of their status as being enslaved people. But it turned out a whole bunch of white people in the South couldn't read either. So they changed the rule to say you can only vote if your grandfather can vote. That was the rule. So that's where that comes from, which is why all the ABS language has changed to legacy as opposed to grandfather. Actually, I thought I was really alert and I changed it to grandparent for about 2 days before someone actually educated me. So how does it look right now? I said that all the requirements, that ABMS, what we've really done is that form is now following function. ABIM really always made the rules. They always wrote the exam. They were always really the parents of this organization. We did have surgeon volunteers, and I would really strongly encourage you to participate in that process. And in the end, we held the door open in the beginning, and we're holding the door open now by being a qualifying board. Now, that is not to diminish the irritation, frustration, or maybe even despair in some circumstances of having to deal with two boards, of losing the identity of being an ABS surgeon. I do see that, but hopefully this helps you understand the brutal realities of what goes into board certification and managing these things. So what's happening now? Everybody who had a certificate that used to be through the ABS has been shifted to ABIM. So if you are holding both your certificates, your original general surgery or any other certificate from us, and your hospice and palliative medicine certificate, you are certified by two boards. Lots of people are. Some people are certified by three boards. It's quite common, and it's actually an issue for the ABMS to try to streamline the work of being involved in two boards so that you don't have to produce a state license once every 5 years for one board and every other year for another board and 45 CME for one and 13 for another. So they're working. That's actually a focus on their part to try to work to simplify things. ABIM has actually already simplified it. So if you look at their website, you will have a heart attack about what it takes to maintain your certificate. You can feel sorry for the ABIM people. That is all waived for surgeons. There's a little checkbox at the bottom of the application. You say you're certified by the American Board of Surgery or anything else, and all you have to do is their longitudinal assessment. That's the knowledge assessment. I say all, I know it's not nothing, but you don't have to fulfill the rest of your requirements. So they've already moved to try to simplify that. You don't actually have to maintain your surgery certificate. I hope you do. You probably feel like you need to, but in fact, you don't have to. You have to have it to be eligible to be certified. You don't have to maintain it. That's actually true of all of our specialties, actually, maybe even all ABMS specialties, I'm not sure. It used to be true that if you wanted to stay certified in pediatric surgery, you had to keep your primary certificate. You don't anymore. The reciprocity thing is that you don't have to follow their other rules. They're actually going to switch to an annual exam from the every other year exam. And that's in part because of the power of the many. Because there are so many people funneling through the single pathway, they now have the validity of exams that they can do it every year. Part of the reason for doing exams every other year is so you can get enough people in one exam to make the exam valid. My one concern, the one thing that didn't really match up well, is the people who do their fellowship in the middle of their training. For many years, we've let people who do surgical critical care do a fellowship after their third year of training. They don't get certified, but they can take the exam. They're sort of held in this neutral land. After they get certified in general surgery, they're automatically certified if they pass the exam in surgical critical care. It's nice to take an exam in proximity to training. We don't actually know how many people that's true of in HPM. It's actually, oh dear. We don't hear who's doing fellowships. Like there's no pathway where the board is notified. So we don't know how to contact them. But you were here. So if you have any friends, tell your friends also. So we did ask ABIM to have a legacy pathway and let those people take the exam in proximity to their fellowship. And they disappeared for 5 days, which to me means that they actually did talk about it. And they said, we don't allow that under any circumstances, and we're not going to make this one exception. I have to allow the autonomy for other boards. I am a little fearful that they're not going to allow people to continue taking their fellowship in the middle of training. So I would keep a very, very close eye on that. We can continue to advocate for that, but in the end, they are, in fact, the bosses now. Oh, that's the end. I had a couple of comments that I wanted to make overall, partly based on some of the things I heard. One is, this isn't the only thing that we're a qualifying board for. We're also a qualifying board for neurocritical care. Anesthesia is the sponsoring board for them. We had 150 people certify in neurocritical care. That's actually a relatively new certificate. When it first came out, I asked the chair of the Trauma Burns Critical Care Board, do we have anyone who wants to certify in critical care? He said, nah. So I said, fine. And then all this press went out about neuro, and it turned out we had a lot of people, all of whom emailed or called me, who did want to be certified in critical care. So we are a qualifying board for them. So this isn't completely new territory. We have other parallels, and other boards have common relationships. I mentioned that we were always looking for the competency of palliative medicine. I think to keep yourself linked in the House of Surgery, the nominating process for the council is open right now. So societies, and you have a society now, can nominate. Individuals can actually nominate peers, and we do have people on the board that happens with, or on the council. The nomination of a society is maybe a little bit more powerful. We didn't specify HPM this year, but it still is valuable. So you can look on our website. We actually send out announcements to the societies, but you didn't exist yet, so you probably didn't get one. But I would strongly recommend that you nominate people. Doesn't mean you'll get someone in every year, but I think it's a really good way to have a voice in addition to Bridget on the board. I think that you're really on the right path. You know, a society, we don't have that Royal College system where everything sits in one house. You know, societies are the collegial place, the learning place, the building an identity and personality place. It's not the boards. It doesn't happen there. So I think that you have what you need as you start in this room. And the American Board of Internal Medicine isn't that bad. A lot of the loathing for them is historic. The new leadership, which has been around for 10 years, is really pretty great. They have a lot of resources, more than we do. They have more money than we do. They have more clout than we do, both at the ABMS and with the government. They have a foundation. They have money. I mean, they have research money. So it's not all bad to be looped in their field. So I think that those are the things that I wanted to bring up based on the conversations that I was hearing. Yeah, and that's it. I don't want this to be seen as, this is a big setback. Somebody said that, it's like 2 steps forward, 1 step back, or kind of learning over and over. Oh, the mountains beyond mountains, the Sisyphusian effort. But we really value this incredibly important field, without a doubt. I'd like to see people's voices be maintained. You can also be on the general surgery board, on the complex general surgical oncology board. There's lots of places you can work. I think you should volunteer for the ABIM, and I think that you should, take advantage of being related to that organization. And that's the explanation. I don't know if it makes anybody feel any better, but at least it wasn't done sort of willy-nilly. I feel afraid.
Thank you very much for your grammar lesson and wonderful talk. And we do appreciate your addressing our concerns. And I think the identity as a surgeon really is important and hard one for us. So that is hard. So thank you for taking it on. My question is, I'm about to research in vascular surgery. I have a reading list. I know exactly how many questions I have to get right. I have this longitudinal assessment that I'm starting in palliative care, no reading list, and no feedback about how I'm doing over the course of the longitudinal assessment. How does the Board of Surgery interact with the Board of Medicine to ensure that they're doing a quality process? So
that's a good question. You don't have to read the whole reading list for vascular surgery, by the way. Just keep it open and available when you're looking at the questions. That's completely allowed. I'm actually sort of horrified when I find out people read all of the references ahead of time. That's not our expectation.
We're overachievers.
The House of Certification decision-making is actually pretty structured. And I know that I did hear a fear that how do we know that ABIM won't just stop letting surgeons do it, sort of shut that pathway down too. So there's a whole process for allowing these things. ABIM, I think I said, started working on this in 2018. And has to go through committees and votes and public comment and various transparent portions through the ABMS. So they had to get their permission before they could even ask us. They were like, we think we should consolidate this in one place. We want to streamline this. Can we approach the other boards? If they were ever, and it's hard for me to imagine, decide that they didn't want surgeons to be eligible anymore, they would have to go through that whole pathway. And that pathway is always spread out to the other boards. So it would come to the table. If I somehow missed it in the wind, it would come to a full ABMS board meeting. So these things just don't happen. And part of the, sort of behind closed doors, part of the decision-making is have the boards agreed to this. So the ABMS doesn't like to get in the middle of wrangling. So unless we all agreed that there was some reason to not do it anymore, we wouldn't do it. To the question, how do we improve quality? We don't. ABMS does that. Everybody has to put their assessments, their rules through a vetting system that gets revisited every 3 years. I have little doubt about them. There are other boards I worry about, but we actually don't oversee their quality. That comes from the ABMS, who oversees ours as well.
Dr. Beiske, thank you so much for taking the time to come here and for really explaining the rationale behind the process. a lot of us felt blindsided by what happened. And what I think I heard you say has to do, what happened what you spoke about is something that has taken place and is no longer going to be changed. But I think I also heard you foreshadow a future development about surgeons in training possibly no longer being able to do a palliative care fellowship during their residency. The implications of that are tremendous.
Are they? Okay, that's good to know.
Really, really tremendous. Think about having to do what I did because I felt between the legacy pathway and the in-training pathway. So I had to enter general surgery practice, take that steep learning curve up in terms of operating independently, and then figure out when was an okay time to take a non-operative year away from my general surgery practice. What I tell people now is that if you can do it, if you know what you want to do early enough, do it in residency so that you can finish your surgery residency and stay on that learning curve without having to take a non-operative year. That's, I think, good advice for most people. I mean, of course, there are exceptions to that. So to now hear that we may be, and hopefully we won't be blindsided when it happens because you just tipped us off. We need to know where to listen and where to involve ourselves to prevent that from happening.
Let me look into that. I said we don't know actually how many people are involved, so I don't know sort of the scale of the problem, but I hear what you're saying, that even if you knew during training and then did it right away, it's still a non-operative year at a kind of a vulnerable period of your training. And we hear that from surgical critical care, even trauma, where you suddenly stop operating before you've really gotten used to operating. So I hear that. Let me run that up the flagpole a little bit and see who the right people to talk to are at ABIM.
Thank you so much for this presentation. Yes, I'm one of the current palliative fellows in this situation. I'm a PGY4. And so thank you for echoing those comments that this does affect a lot of people. When I posted on social media that I was doing this fellowship, I had 6 random colleagues from across the country reach out to me and say, wow, this is something I'm really interested in. My program, I am the palliative care ambassador. Any applicant who indicates an interest in surgical palliative care is funneled to me in their application interview process. And I was talking to someone on the phone once a week last year. So this is definitely a growing thing, which is fantastic. And I'm wondering if it would be helpful in the vein of, if you build it, they will come. Would it be helpful to get data on how many trainees this would potentially affect?
Definitely. It would definitely be helpful. Even for surgical critical care, we had to work with the other boards that do critical care, anesthesia, medicine, pediatrics. I don't remember if there's other ones, to be allowed to let them, this long predates me, to let our trainees do their fellowship in the middle. And the winning argument was that most of those fields have 3 years of training. So what's the rationale between not letting our people do 3 years of training? But, at the moment, they do not let anyone else do that. So, so let's keep this conversation alive. And yes, finding out how many people are doing fellowships would matter.
Yeah, this is super helpful. Thank you. I would just add too that another problem though, for the other programs that, only have 3 years or that aren't doing that, a lot of the HPM fellowship programs don't like surgical candidates already. There's a number of those. Yes, even though we're there. And for trainees that are not staying at the institution where they're doing their residency, they struggle to be able to operate. You mentioned trauma and critical care, but a lot of times the fellows are taking call or acting as an attending or doing things where they do get at least a little bit of time in the OR.
Yeah.
And that's a real challenge for the fellows to try to figure out how to operate. And especially if you are, like someone mentioned, going back later in your career, and I think you said it, you can't have a gap in your case log. That's a problem. So I guess I would reiterate those issues. My question though, so as somebody who's now practicing only palliative medicine and I'm not operating, can I still, and if this is too detailed of a question, but can people like me still maintain the ABS board certification without a case log? Because I won't have one anymore.
Well, actually, we're going to drop the case log requirement.
Perfect.
For a variety of reasons. We do have a clinically non-active, but you wouldn't be clinically non-active. But yeah, we were about to drop the case log requirement for a variety of reasons. Yeah, yeah, it's not uncommon for people. A lot of surgical critical care people don't have a case log. You end up having to like fill out a paragraph of explanation or something. I thought you were going somewhere else with that question.
Hi, I just wanted to echo a concern that she had. I have spoken with some program directors in palliative medicine when all of this happened. And particularly now that the surgical residents who do this are going to have a 3-year gap, in some cases 4-year gap before they can sit for their boards, and at that point may not sit for their boards. It reflects poorly on the palliative care programs, and they need to worry about their accreditation. And so in speaking with some of the palliative care program directors, they're now concerned about taking on surgeons.
Yeah, that's an interesting point. Thank you. So the lower board pass rate reflecting on their ACGME accreditation. I hear you.
Thank you very much for coming in and speaking with us. Just to raise one other small issue is I applied to take boards and we'll take them in 2 weeks. But I literally had to call and email both boards to make sure that they were communicating so that I could even actually apply and take it. And so since we're moving completely to the internal medicine side of things being in charge, there needs to be a better way to make sure that the two societies are communicating so that I don't have, so that other people who are applying don't have to literally call and email and say, you really do have to let me take this test.
Yeah.
Like, please don't make me pay late fees because you can't communicate. Yeah.
We might have to talk more about like the details of what happened so I can understand that better. Because you're right, that's not supposed to happen. It is the first year. But yeah, it certainly should never happen again. So I may get your email address on my way out.
I just wanted to thank you, Dr. Beiske, for your talk. And we're going to take a 5-minute break and then we're going to transition to the last panel. And there's still a social hour at the end. So I'm sure we can ask questions all around at the end.
Thank you all very much.